So good afternoon to everybody. Here we are again after this wonderful lunch, and it doesn't need any more introduction. I mean, those of you, everybody of you knew Dr. Ghossein before, and now you know him even better. So please, on rare thyroid carcinomas.
Okay. I hope everybody had a good lunch and coffee. We're going to talk now about really, you hear me, right? We're going to talk now about a very serious subject. So it will not be only anaplastic carcinoma. We'll talk also about some entities that enter in the differential diagnosis. And because the misdiagnosis of anaplastic carcinoma is really catastrophic, we're gonna, in the slide session, also look at cases that are some difficult, some very banal, but because let's make it a goal for ourselves that after this, 2 hours, we really, all of us can better diagnose anaplastic carcinoma, because here it's serious business. So the basis of this lecture is a very large, very comprehensive study on the histologic, immunohistochemical, and molecular data of 360 cases of anaplastic carcinoma. Two important things to know: the name of the person who really did most of the work, Dr. Binshu, who is a colleague of me and Dr. Katabi at Memorial. And also another important thing, that this was a great collaboration with Dr. Anthony Gill. I don't know if you know him, but he's by far the best endocrine pathologist in Australia, one of the best in the world, and a wonderful person to collaborate with. So because this is a rare entity, we put 360 cases together, and this is the biggest series as far as the depth of the analysis. So we're gonna first talk about the basics. So the clinical presentation, how does this terrible tumor look under the microscope, very important immunoprofile of anaplastic, and we're going to spend a lot of time on the differential diagnosis and also on the molecular profile and some targeted therapy. So let's go to the basics. We all have to go to the WHO. So, anaplastic carcinoma is a tumor, a highly aggressive thyroid malignancy composed of undifferentiated follicular thyroid cells. So, our role for decades has been to make this terrible diagnosis. But the good news, that now there is treatment for anaplastic. I mean, there's a variety of treatment modalities, and our role is sometimes to also guide the precise treatment, as I will show you at the end. Okay, so the clinical presentation is very important for anaplastic carcinoma. Never, never, ever, ever make a diagnosis of anaplastic carcinoma without talking to the clinician, for two very important reasons. First, if you don't talk to him or her, you can make the wrong diagnosis. And believe me, even if you make the right diagnosis, this is something they will always hate, is not to know that there is anaplastic carcinoma. And once a colleague forgot to call one of the endocrinologists, and she really sent me a very nasty email, telling me, not ever you and your people do that, because you have to understand that it's very difficult to announce to somebody that they have anaplastic carcinoma. And actually, the clinician has to prepare himself or herself psychologically for this drama. Usually, a visit for anaplastic carcinoma is 2-3 hours. Because you have to announce so many bad news, versus papillary microcarcinoma 5 minutes. So, and I understand them. They told me so many times that once they had announced anaplastic to a physician, he said, oh my God, I'm seeing my coffin, I'm seeing my wife crying. I mean, it was, so please don't ever make this diagnosis without picking up the phone. I know the young generation doesn't like to pick up phone, they like to send email. Nobody, would you like somebody to announce to you that your loved one died by email? No, so please be a good doctor and do the right thing. So, anaplastic carcinoma, we have to call the clinician because it's a large, rapidly enlarging thyroid-based mass, okay? Thyroid-based mass. And here, be very careful, because some clinicians don't know how to palpate the neck. So once I remember I made a mistake. It was an FNA. The cytopathology showed it to me, and it could be anaplastic. We told the clinician, yeah, it definitely could be anaplastic. It's rapid, no. And the oncologist told me, no, it's thyroid based. Then I got 3 weeks later a nasty phone call from the chief of head and neck surgery. Ronnie, you screwed up the case. What do you mean? Well, this lady, she has a metastatic lung carcinoma to the neck. I said, but he told me it's thyroid based. No, it's not thyroid based. So not everybody knows. So you have to ask the only an endocrinologist or head and neck surgeon, and please do the right thing and tell, let's call him Mattia, right? The endocrinologist. Mattia, do you want me? Once I told the guy, John, do you want? So I'm going to put in my report that according to it's thyroid based. No. So he was not sure. Luckily now, you know, a lot of patients have CT scans, so this is solved. But it's very important, large, rapidly enlarging and thyroid-based mass. The age is extremely important. It hits people in the 60s and 70s. Of course, you can have young people with it. The youngest person I saw is 24 years old. Under the age of 40, you have to be super duper doubtful. You have to look for everything that's not anaplastic because it's very, very, very unusual. Now, they have been reported in the literature of kids with anaplastic thyroid carcinoma. You can take it and like this here and throw it to the garbage because this doesn't exist. This is really, these are, in my opinion, simply poorly differentiated thyroid carcinoma that were misdiagnosed. So, despite the advances in treatment, this is nearly always fatal disease. So you have to, again, I mean, I'm sorry to repeat myself, but what is at stake is enormous. So basically, when you make a diagnosis, it's like you condemn somebody to the death sentence. I know you're lucky in Europe, you don't have the death penalty, but we have it in the US. So really, it's like sending somebody to the death penalty. So you can take 15 or 20, you can take your time making this diagnosis. There was an American president, I won't say his name, the son of another president. He used to, when he was governor of Texas, he used to take 10 minutes to decide whether he's gonna grant clemency to a Bush Jr., to a criminal. So really take your time. It's okay if you spend 1 hour, nothing will happen to you. Your husband will not leave you, your wife will not leave you. It's much better to spend time in the case. Okay, now the first truth that the majority of anaplastic carcinoma are associated with a better differentiated component. Actually, if you look carefully, 60% of them, and most of these are well differentiated, and papillary thyroid carcinoma is, of course, the most common. In particular, there are a lot of told cell variants. You can find also other entities like Hurtle cell carcinoma. You can find very rarely follicular carcinoma. And it's not unusual to, I mean, not unusual, but you can find poorly differentiated because either as the precursor, so poorly differentiated anaplastic, or as the bridging component. You have a papillary carcinoma, then a poorly differentiated, and the anaplastic. So you have the whole spectrum of thyroid cancer drama on one slide in one patient. All right, so let's give you examples so you can believe me. This is on your right here. You can see a papillary carcinoma. It's actually making follicles in this case. And on the left, this is anaplastic carcinoma. So anaplastic carcinoma doesn't make follicles. It doesn't make papillae. It doesn't even have the nested growth pattern that you see in insular, which is, you can say it's a kind of differentiation like fetal thyroid. You don't have that. You have sheets of cell, often, as we'll talk about it with necrosis. But now let's concentrate on the better differentiated component. You can have with Hurtle cell carcinoma, this is the second one, don't be surprised. Here you have a Hurtle cell carcinoma on the right. On the same slide, you have an anaplastic carcinoma. Now, regarding the histology feature, so histologic feature, how do we make this diagnosis? First, you really almost always you have marked, not always, almost always, marked nuclear pleomorphism, so you have to look for that. Now, the mitotic count is usually elevated. For me, it's 5 or more. But actually, there are cases, bizarrely, with a low mitotic count. If you, in core biopsy, actually, it's not that unusual because obviously you have a little piece of the tumor. So be careful, don't back off from this diagnosis. if you have a low mitotic count. But usually in this situation, you have micronuclear polymorphism, and you rely on other instruments, like the immunoprofile. And I'm going to repeat it maybe 10 times. Anaplastic thyroid carcinoma almost never has thyroglobulin by immunostaining. Now, tumor necrosis. This is quite common. It's much easier than the tumor necrosis that I showed and where I fought with Mattia and Giovanni. It's really obvious. Sorry, guys, if you disagree with this, let's not talk to each other tonight. And so, in addition, there is another very interesting finding, which the fact that it has a lot of neutrophils, so much that actually some patient presents with neutrophilia. And we did a study on anaplastic carcinoma, again with Dr. Shu. We found out that actually the neutrophilia at presentation is a poor prognostic factor. Now, for those of you who really like thyroid, you have to know that there is also a lot of macrophage. I didn't put a picture, I wish I did it. And this is why, by the way, for many years, until next generation sequencing came, we couldn't do a very good genomic analysis of anaplastic because Mattia, they were filled with all this DNA from the macrophage who were competing. Actually, I wish I put that picture. I have a picture where you have one anaplastic carcinoma cell surrounded by 5 macrophages. So if you do a CD68 or CD163, it's very easy to find a lot of macrophage in them. Now, vascular invasion. Now, these tumors are often widely invasive, not always, often. Some lucky patients have tumors limited to the thyroid or even encapsulated. Now, in regard to vascular invasion, extremely common, of course. Now, there are 2 types. You have, like on the top picture, the vascular invasion. I'll show you an example that you see in the carcinoma that me and Giovanni showed you, like Hurter cell carcinoma, basically a tumor plaque hanging in the lumen of a vessel, intracapsular, extracapsular vessel. But you have another type of vascular invasion, so where it is really the tumor cells are invading the vessel from the outside, like in the lower picture here. Now, what about the growth pattern and the cytologic features? Now, if you look for the predominant growth pattern or the predominant histologic cell type, in 26% you have spindle cell. That we were all told this in residency. Of course, within that you have a spectrum. You can have very hypercellular tumor that look like sarcoma. You can have paucicellular tumor where you would think maybe you're dealing with just fibrosis. And you have a tumor with a myxoid stroma. Now, you can have also, as I said, the other very important issue is pleomorphism. What I mean by that, a very big difference in size and shape, especially in the size and shape of the nuclei. Now, you can have, a lot of people don't know that, you can have an anaplastic that looks like a squamous cell carcinoma with everything, the squamous cells, the keratin formation, all of the rest. And you can have tumors which look epithelioid or epithelial, but they don't make squamous nests. We'll call them epithelioid. Now, you can have even more unusual things, like you can have this rhabdoid look, then you can confuse it with a SMARCB1 deficient malignant tumor or with a rhabdomyosarcoma. You can have, very rarely, and we will see a case, tumor that are osteoclast giant cell rich. The osteoclasts are not the tumor cells, they are just macrophages coming for the ride here. And we will look at one case later. Now, very rarely, you can have chondrosarcomatoid or even osteosarcomatoid differentiation. Now, what is not unusual is to have a mixture of morphologic features. So in this particular case, you have in the bottom a squamous area, and in the top an osteoclast giant cell rich area. Now you can all relax and maybe forget most of what I said, because luckily for prognosis, that doesn't matter. I remember the old surgeons asked me, "Hey, Ronnie, this is spindle and giant cell anaplastic?" I said, "Doesn't matter, Dr. blah, 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 and Dr. blah, blah." Yeah. So basically, we did in that study, we did by univite analysis. It doesn't matter whether you have a paucicellular or a rhabdoid or epithelioid. They're all gonna do, unfortunately, poorly. Now, this is now really important, the immunoprofile of anaplastic. So this tumor is undifferentiated. So don't be surprised if some of the cases don't even have keratin. And we'll talk later how to deal with that. Now, the first thyroid-specific marker that disappears, and I'll talk about it for a long time, is thyroglobulin. Again, I repeat myself, if you have thyroglobulin in a tumor, think 2 million times before you diagnose anaplastic carcinoma. And I'll tell you later about an interesting case we had a few weeks ago. Then the other marker that is lost is TTF1. So usually this tumor, if they don't always have TTF1. Most of them don't have, and when they have it, it's focal. But what remains really in a good amount of cases is PAX8. But here be careful, because with the polyclonal PAX8, you can pick it up in 70% of the cases, but you have to pay a price for this, as I'll show you today and later in the afternoon. And with the monoclonal PAX8 that now we use in 54% of the cases. Now, regarding the keratins, really doesn't matter which keratin you use. The most common one is usually CAM 5.2, A1, A3. CK18, we like it. One of our previous chair used to call it the keratin of desperation, because you do it always when you're dying to have epithelial differentiation. Now, there are other markers that are quite important, and again, we'll talk about it a lot, especially BRAF-V600E is positive in 40% of the cases, and it's important in the differential diagnosis as well as in prognostication, as we'll see. As I just mentioned an hour ago, there is now a good antibody against the mutated Q61R. It goes against NRAS, HRAS, or KRAS, and it's seen in 50% of cases. Now, P53, it can help you in the differential diagnosis in some cases. Just to tell you, you either have overexpression, so all the cells are positive, or you have the null type. Basically, there's absolutely no P53 protein. All the cells are negative. Now, the Ki67, as you will see, we use it sometimes for differential. It's not great, But remember, it's like mitosis. It can be low. It can be surprisingly low. Now, in practice, what should you do when you have an anaplastic? Again, here, please don't ever make a diagnosis of anaplastic without immunostains. I mean, you will be talking about a careless person. You'll be one of the most careless person in the world. So always do cytokeratins. Always do TTF1 thyroglobulin and PAX8, preferably monoclonal PAX8. And as you will see at the end of the talk, you have to do BRAF-V600E. Okay, I6 and P53, you can use them depending on the differential diagnosis. All right, so let's try to see this in real life. So this is an interesting case. You have a papillary carcinoma on one side and an anaplastic with osteoclast giant cells, osteogiant cell rich anaplastic. Okay, so let's look at every stain one by one and component by component. So the anaplastic carcinoma is positive for cytokeratin A1, A3. The anaplastic component shows PAX8 positivity. And very importantly, it shows less TTF1 positivity, few cells, if you can see them, and super duper important, sorry to bother you with this, it doesn't show any thyroglobulin. Now, what can be very helpful is to do BRAF-V600E for the differential diagnosis, as we'll see later. But one thing that you have to know, that the mutation is a driver mutation. So it's present in the papillary, and it remains in the anaplastic carcinoma component. This is a case I wanted to show you where the driver is, the main driver is the RAS Q61R. So, all right. now we get to the really important part of the talk. So, the differential diagnosis of anaplastic. So we're gonna go slowly, okay, group by group. So the best way to do it, and that was an idea from Dr. Bin-Shu, is to put them in 3 boxes, in 3 buckets. The first, anaplastic squamous cell carcinoma. Second box, spindle and pleomorphic. Third box, epithelial and epithelioid. Now, for the squamous anaplastic, you have the problem with anaplastic is not only you have malignant tumor that enter in the differential, but also benign tumor. Just imagine the mistake you will do if you label somebody with a benign tumor anaplastic. I mean, just imagine. So, squamous cell carcinoma of the upper airway digestive tract is, of course, a consideration. We look at a case, an extension from the larynx, for example. Now, other things are very rare, like mucoepidermal carcinoma, sclerosing mucoepidermal carcinoma with eosinophilia. We'll look at it in the slide session. A very, very dangerous situation is squamous metaplasia. For the spindle cells, when one says spindle cell in thyroid, you always have to think about medullary carcinoma. We'll talk about it tomorrow, but we'll talk about the differential today also of spindle cell variant of papillary carcinoma, a sarcoma, primary, unusual, or metastatic. We'll talk also about benign lesion. I have seen these mistakes where a spindle cell nodule, due to the FNA, can be mistaken for anaplastic. We'll talk about endocrine atypia, a completely clinically insignificant histologic feature that can lead you to the wrong diagnosis of anaplastic, and adenoma with spindle cell metaplasia. For the epithelial epithelioid, there are usually no benign tumor that enter, or benign lesion that enter in the differential, but just metastasis and some super rare things, except for lymphoma, that is a possibility, and we'll see a few cases of that. All right, so let's start mollo with squamous anaplastic carcinoma. So the first thing is, how do we differentiate it from laryngeal squamous cell carcinoma? Well, you cannot use P40, you cannot use P63, you cannot use high molecular weight cytokeratin. Of course, you cannot use keratinization. So what can you use? Here, the great test, the super test, is PAX8. Because PAX8 is negative in squamous cell carcinoma of the head and neck. Another very helpful, maybe more better than PAX8, is BRAF V600E, because so unusual. I don't know if it exists in upper airway digestive tract squamous cell carcinoma, that you can use it. And of course, it becomes easy when you have a better differentiated component, let's say a papillary carcinoma living with the anaplastic. So here, for example, you can see an anaplastic carcinoma with a PAX8, and here you can see BRAF V600E immunostain positive in an anaplastic carcinoma. Now, talking about squamous anaplastic carcinoma, you have to know that squamous anaplastic carcinoma, especially the anaplastic that are purely squamous, have a very strong relationship with the tall cell variant of papillary carcinoma. This was described by Dr. Livorsi a long time ago, 32 years ago in 1991. And we don't know why. The tall cell variant often give rise to anaplastic squamous cell carcinoma. You can see a very nice example here with the papillary carcinoma on the top, small pictures, and the anaplastic on the squamous cell on the bottom picture. Now, in the 2017 WHO, I don't know why, pure squamous cell carcinoma was put in a different category than anaplastic. They thought there's something called squamous carcinoma of the thyroid that has nothing to do with follicular cell differentiation. That's wrong. There is definitely this is somewhat derived for follicular cell, and Dr. Bin-Shu in that paper brought the evidence. For example, there are in a majority associated with BRAF V600E. As we said, BRAF V600 doesn't exist in other squamous cell carcinoma. They have also similar outcome than anaplastic carcinoma. they also have PAX8 often. So based on that, in the new WHO, now squamous cell carcinoma is just a banal subtype of anaplastic carcinoma. Now let's look at a catastrophic mistake if it happens. Squamous anaplastic versus squamous metaplasia. So here again, you cannot count on creatine purs, on immunohistochemistry for CK56, 34B, P63, P40, even PAX8, because if the squamous metaplasia comes from a papillary carcinoma, it will be PAX8 positive. You cannot rely on TTF1 thyroglobulin, although it's not completely true, but in general you cannot, because they both lose it. And of course, they both can be BRAF V600E positive. You can have a papillary carcinoma with spindle cell metaplasia, and there is no reason why BRAF V600 won't be in the spindle cell component. So the only thing you have to get you out of this drama is your eye. So you have to look for nuclear pleomorphism. You have to look for an absence of mitosis and necrosis. Now here Ki67 can be helpful, P53 can be helpful, obviously no abnormal expression in squamous metaplasia and not elevated in squamous metaplasia. So let's show you what it means. So this is an FNA site, a banal FNA site, and if you go next to, if you go around it in the wall, you have this squamous metaplasia there. You notice that there is not much nuclear pleomorphism. There is no necrosis, no mitosis. Also, there are not big sheets of squamous cells. And let's see if the immunostain help us, yes or no. So this is actually a case of squamous metaplasia. So forget about PAX8, staining the PTC and the squamous metaplasia. Forget, of course, about P43. Forget about BRAF V600E. Now, the Ki67, comme ci, comme ça. P53, it could be helpful, but not always. But what really is helpful, if you compare it to a squamous anaplastic carcinoma, you can see that in this one, there is necrosis. In the inset, you see nuclear pleomorphism. You have to go away from the area of FNA changes. And of course, there is this kind of perineural invasion, and especially the vascular invasion involving the vessel. Here, you can see again that the PAX8 and the BRAF V600 do not help. They are positive in squamous metaplasia and anaplastic. In this case, it's an anaplastic that is BRAF V600E positive and PAX8 positive. But here I can say that the P53 was helpful, because you can see that the better differentiated component, you have a few cell staining, so it's a wild type staining, while the anaplastic is more diffuse over expression. All right, so yeah, we're done with squamous. Hang on with me. Okay, let's attack the spindle pleomorphic anaplastic carcinoma. Now, this is really, we're gonna talk about it 3 times this afternoon. So endocrine atypia. So endocrine atypia, what it is really under the microscope. So basically you have very large, really bizarre pleomorphic nuclei with smudgy chromatin. They are kind of often dispersed. They're not in clusters. They can be, but usually not. But very importantly, they can be seen in benign or malignant lesions, so no value as far as whether it's cancer or not. And very importantly, endocrine atypia, even malignant lesion, actually, I saw a case the other day, lack mitosis and necrosis. And very importantly, again, sorry to repeat it, they retain thyroglobulins. Very important to do this marker, as well as TTF1. And they lack abnormal P53 expression, like in this case that you can see. So now, regarding spindle cell that can be confused with anaplastic, a benign condition, is the post-FNA spindle cell nodule. Now, here, again, you have to go by histology, no pleomorphism, no mitosis or necrosis. The spindle cell often living next to an FNA site. And often lack of course, lack of BRAF fixes on the mutation. So another also tumor is papillocarcinoma with spindle cell features. Some people call it spindle cell variant. They do exist. They are rare. Here again, it's the same story. You have to you can rely on morphology, no pleomorphism, mitosis, necrosis, but also you can rely on thyroglobulin positivity and diffuse TTF1 positivity. Now, there are malignant spindle cell lesion or sarcoma in the thyroid, and maybe the most important one is angiosarcoma, common in areas of endemic goiter, like in the alpine region of Europe, where we are here. It's interesting to do a Trento paper. It's usually in old patients, like in anaplastic. Unfortunately, it's rapidly fatal. It can be cytokeratin positive. It's TTF1 and thyroglobulin negative. The big difference is that here you can do vascular marker and it makes a difference. They're usually BRAF and RAS negative. Now, of course, I know Mattia will ask me, what is the threshold? When should I do a marker? I don't do a marker on every anaplastic carcinoma, but once you see, like in the upper right picture, spaces that look like vascular channel lined by ugly cells with red blood cells, you do it. What do you lose? Now, the chances that this is an angiomatory type of anaplastic, you have a lot of anaplastic that have these artifactual spaces, but what do you lose? Nothing. Just an ERG stain, a CD31 stain. Now, I was taught by some very good pathologists that sometimes the shape of the nucleolus, but it's not a very reliable criterion. It's usually in angiosarcoma like a triangle. But another, a little bit helpful is the intracytoplasmic vacuoles. Sometimes they can be microlumen of vessels, like in this case of angiosarcoma, and you can see that it was positive for CD31. So now let's go to epithelial and epithelioid anaplastic carcinoma. Now it's getting more difficult. So, okay, we're not doing the slide session here, but maybe we can briefly ask my friends here. Okay, so this is a 59-year-old with a rapidly enlarging thyroid mass. Anaplastic carcinoma or not? Of course, there is necrosis, the cells look ugly. Huh? What? Wow, who said that? Oh, he's a resident? No, okay. So yeah, so this is actually a lymphoma. It's a typical mistake, very serious mistake. And we'll talk in the slide session. I will show you a really cool case. So not always, I do lymphoid marker in anaplastic. In small hospitals, they do it all the time because they're so scared, but I don't do it. I do it only because when you look at this lymphoma that can be confused with anaplastic, almost all of them, they are typical areas of lymphoma. The cells are small and pleomorphic, unusual in anaplastic. And of course, once you do the markers, definitely you can make the differential diagnosis. Now, this is much more challenging. So this is a 63-year-old man with a diffuse thyroid enlargement, cervical and mediastinal lymphadenopathy. So you can really see cancer here throughout the thyroid. There's a lot of vascular invasion. Anaplastic can have a lot of vascular invasion. And when you look at that case, you notice that is positive for TTF1, negative for PAX8. It's impossible for a thyroid tumor of follicular cell origin, except the cribriform molar thyroid cancer, which is not a follicular cell origin. So it's impossible for a follicular cell origin to lose PAX8 before losing TTF1. It That's not how things happen in life, you know. So it's TTF1 positive, PAX8 negative. It was, of course, napsin positive, thyroglobulin negative. Quick phone calls. You ask, hey, Jimmy or Agnes, can you do a CT scan, PET scan? And they say, oh, I'm sorry, there was a lung mass. Yeah, the patient is a smoker. I'm sorry to bother you with. Okay, so yeah, so this was a lung carcinoma, non-small cell, metastatic to the thyroid. Now, this is an opportunity to talk about metastasis to the thyroid. It's not very common, less than 1% of thyroid malignancy by far, and you are all of you have been told this. Clear cell renal cell carcinoma is the most common culprit, followed by lung, breast, lower GI melanoma. These are not autopsy series, right? This is a really surgical specimen. It may present as solitary thyroid mass. I have to tell you, though, that these days, you know, with the advance in imaging, most of the time it doesn't happen like this. It's really rare. Most of the time, there is a history of renal cell, and simply the clinician did not pay attention to the history of renal cell, or the pathologist missed it, you know, or did not look. I had a case like a few weeks ago where actually the pathologist did not know there was a history of renal cell carcinoma. So yeah. So this is about, now we're getting into really difficult stuff. Okay, if one of your residents, Mattia, makes this diagnosis, I'm ready to jump. No, I'm not going to do this because it can happen. I'm ready to invite him to the best restaurant in New York, but you have to pay for the plane ticket, okay? Okay, 16-year-old with a thyroid mass. One second now. Who thinks this is anaplastic? Just based on the age, forget about it. All right. Even Giovanni will not be able to make this diagnosis. What? Okay, I'm not going to say what it is. Okay. So, here you see a little like these morals. My God, there are good pathologists here. This is unbelievable. So it was positive for cytokeratin, negative for PAX8, and positive for CD99, which is by no way specific, but it was a diffuse membranous staining that is very sensitive to the Ewing family, sarcoma family of tumors. Now this had the EWS1R1 Fly1 confirmed by FISH and next generation sequencing. By the way, guys, be careful, FISH is not perfect on paraffin, so you can, I have seen mistakes. I actually done mistake because of the FISH. So in the United States, this is called adamantinoma like Ewing sarcoma. In Europe, and I think you guys are right, by Sobino C. Morris, I think Giovanni did it, carcinoma of the thyroid with Ewing family tumor elements. I think it's closer to that, but nobody knows. This is another example where if you have a gene rearrangement, you don't wait for the behavior, you jump on the conclusion based on a molecular finding, like people did on histopathology with the follicular variant. Now, these tumors occur in relatively young people, 16 to 42 years old. It has squamous markers like P40, AE1, AE3. Supposedly, it has a better outcome than traditional Ewing sarcoma. Honestly, I don't know if all this is true. There are so few cases. Some people think it responds better to a sarcoma protocol, and maybe, I have no idea. Maybe it's completely not based on data. Maybe in young people it's a sarcoma, and older people it's a carcinoma. I have no way to know. Anyway, let's forget about this entity. Now, in anaplastic carcinoma, what does matter? Once the patient has anaplastic carcinoma, what are the issues that matters? So, there is no question in this study we found, what other people have found, that encapsulation, size are important. Obviously, if you have a little anaplastic, a 5 million is better than a 4 centimeter anaplastic. If it's encapsulated, always better than it's not encapsulated. Dr. Rosa used to say that. Encapsulated thyroid tumor always better than non-encapsulated. Of course, if the margin is negative, is much better. If the percentage of anaplastic is small, it's much better. And often they ask us all these details, and you should give it to them. However, when we did in this big study, multivariate analysis, the only thing really that matters, and this, so it didn't change for, I don't know, 70, 80 years. The only thing that matters is age, the older the worse, resectability, and I mean whether they left tumor behind or not, because we did the analysis in those, in all anaplastic and those who were resected. And of course, I mean, if you leave anaplastic behind, you are in bad shape, basically. Now, this is a horrible tumor, and the only way to treat these patients is to understand the biology of this tumor. I won't bother you a lot. I just will throw on you two concepts. The first one is that the driver, BRAF V600E and RAS mutation that are present in better differentiated thyroid carcinoma, like classical papillary carcinoma for BRAF V600E, RAS mutation for follicular carcinoma and PTC and papillary carcinoma follicular variant remain, as I showed you, in anaplastic carcinoma. But why they're anaplastic? Because they have secondary mutation, additional mutations that give them this terrible behavior, chiefly P53, 63% in anaplastic, and in poorly differentiated, it drops down to 10%, in papillary carcinoma less than 1%. Of course, Giovanni gonna love this one, third promoter mutation, 50% in anaplastic, 40% in poorly differentiated, it drops down to 10%. Now, this, I really believe it very strongly because I have seen it in mice. We are lucky we have the chief of endocrinology now, he's the chief of a bigger department, Dr. Jim Fagan, who reported the first BRAF V600E in papillary thyroid carcinoma. He had a huge transgenic mouse problem, and believe me, these poor mice, when you put BRAF V600E, you have to wait many weeks for a papillary carcinoma. And if you let them live a lot, at the end, some will develop anaplastic. If you put BRAF V600 and P53, it's like an explosion. All of them develop anaplastic quickly. And regarding the molecular, the prognostic value of molecular markers, unfortunately, even with our huge series, we did not have enough genotype cases to do multivariate analysis. But I can tell you one thing. Within anaplastic, if you have BRAF V600E with TERT, or RAS mutation with TERT, you have this combo, BRAF and TERT, RAS and TERT, you do worse by univariate analysis than if you have BRAF alone, or RAS alone, or TERT alone, Giovanni, or wild type alone. Now, you know, because this is a terrible disease, and because really chemotherapy and radiation that has been used for 50 years do not always help, oncologists have tried, they have thrown on it everything, you know. They throw on them multi-kinase inhibitor, like sorafenib, as well as specific kinase inhibitor, like BRAF, like verafenib against BRAF, MEK inhibitor, trametinib, anyway, so forth and so forth. But what really works, and here everybody please wake up, I know it's the afternoon, but please wake up because this is important. There is a combo that was found purely by luck by MD Anderson, and what, you see how jealous I am, I can be petty. And what I hate about it, that we, believe it or not, at Memorial, we treated the mice like this, and they all responded so much that, believe me, Giovanni, I used to look at these mice after they got this, and there was almost no tumor, just fibrosis. Of course, you know, in my brain, I said, yeah, mice are not humans, doesn't mean it's gonna work, you know. And they're so lucky, they had a basket trial, and they threw all kinds of cancer, you know, basket trial, where it's only based on mutation, and bingo, they had incredible response for the combination of a BRAF inhibitor, dabrafenib, don't remember these names, and a MEK inhibitor, trametinib. So you hit the MAP kinase pathway in two places. But to respond to that, you have to have BRAF V600E mutation. And it was really shocking. If you give it in the neoadjuvant setting, before the surgery, you have like, I'm not kidding, it's like a miracle. Look at this case. Like this pre-treatment, post-treatment, you don't even think it, you think, oh, is this the same patient? You know, it is unbelievable. The high pathologic response rate, durable local regional control, but of course, like every time in targeted therapy, not everybody responds. And unfortunately, like always in targeted therapy, like in chemotherapy, at the end, Mattia, nobody responds. Right? It's not like immunotherapy where you have a little bit, the curve goes completely down. However, it's so good, but you have to imagine, I mean, you have anaplastic is a catastrophe. You see people die in 3 months. So this actually treatment is approved by the Food and Drug Administration, by the FDA. Actually, it increases also survival. The median in anaplastic is, the median survival is 6 months. It went to 12 months. I know it's not a big deal maybe, but I don't know, for a guy to walk in his daughter's wedding, it could be a big deal. Also, there is something, it gives you a much better quality of life than chemotherapy. It has side effects, but better. But you know, there's another thing what you have to think about in this anaplastic. I don't know if you talk about it in your tumor board here. Quality of death. Because it's much better to die, if I have to choose, from metastasis than from anaplastic carcinoma. It's a horrible, horrible death. For the family, for everybody, you do a tracheostomy, it recurs in the tracheostomy, it's a horror show. So really, it is an incredible advance. It was unthinkable 10 years ago. Now, this is one of these cases. The pre-treatment, you see the anaplastic is very cellular, and here is the after neoadjuvant therapy. Nora saw some of these cases. So you see that there is, most of it is fibrosis. There is some anaplastic carcinoma that unfortunately survived, but was really cool. By the way, this is the area when the anaplastic disappears. The area is filled, of course, with lymphocyte, inflammatory cells. The response rate, as I said, like targeted therapy, is very variable from 10% to 100% response rate. And we are really, in mice models, studying very well this tumor to understand why some respond, why some do not respond. A lot of work is going into it with tens or hundreds of thousands of dollars. But what is incredible, look at this, Mattia. The papillary carcinoma doesn't respond. So the anaplastic respond, but not the papillary carcinoma. And we're not going to go into details. We don't have time here, but it is due to all kinds of issues. It is due maybe to the macrophage. The fact that actually anaplastic have more macrophage, maybe that's why they respond better. But, you know, I'll let the scientists figure it out. Anyway, from a practical point, it's very important this, because if you look at the 2021 American Thyroid Association guideline for anaplastic carcinoma, once an anaplastic carcinoma comes, I get an email, a phone call. Ronnie confirms anaplastic, or Nora, BRAF status. So immediately a BRAF V600 is done. Now, if the tumor is resectable, they will go ahead and resect it. If not, they will give the dabrafenib. And of course, depending on the response, they do something or another. We're not going to go into the detail. But the hope here is, for example, to be able to take, you know, an anaplastic that is invading the vocal cord without doing a laryngectomy. I mean, this is unbelievable. I mean, it's like a dream. Anyway, our job is to tell them basically, BRAF is positive or not. And you have to do it quickly. This is anaplastic carcinoma. It's not a nice tumor like papillary carcinoma waiting for you to make your decision. So next generation sequencing, I don't know, Giovanni, in your lab, but it takes us many weeks. So what we do, there are two options. You either do a quick PCR assay, or you do immunostain. And the immunostain is very, very good, the VE1 antibody. And in that paper, we found out that it has very good sensitivity and specificity. And look how it's staining very well in this squamous anaplastic, here in the osteoclast giant cell-rich anaplastic, and in a rhabdoid anaplastic. One word about immune checkpoint inhibitor. Actually, you can forget everything because the primary data is not exciting. The treatment data is not exciting. Some people ask you to read the PD-L1 anaplastic. I have no idea how to do it. Giovanni, if you know, please teach me. Nobody knows how to do it. Almost very rarely they ask me about it. Unfortunately, we need to do more studies. Okay, so now to finish this talk, the take-home message. Anaplastic can have various histologic features, but nobody cares about it prognostically. Of course, important to report on encapsulation, margin, percentage, and size of anaplastic carcinoma. But remember, the only independent factors really are age and resectability and gross residual disease. And I said enough. BRAF-V600E status is very, very important. I immediately, once I get this, and I know it's anaplastic, I go myself to the chief immunotechnician, told him, look, René, look at me in the eyes. I know it's Friday, but you have to get me this by tomorrow morning. And he gets it to me by tomorrow morning, and we tell them. And when it is BRAF-V600 negative, they're very, very upset. And that's it for anaplastic. Thank you. 72-year-old male with a rapidly enlarging, within 3 weeks, right neck mass. Really not fun. So, this thing again. Yeah. Okay, so so what they did here, Giovanni, you're going to be happy. They did incisional biopsy.
So they got the right diagnosis then?
Oh, please, okay. Sometimes you can be wrong, Giovanni. Okay, so here it's a tumor. It doesn't make any follicles, any papillae, any insular growth pattern. Pleomorphic. There are mitoses. All right, so you all gonna do immunostains, right? So let's see, maybe the young people, we can ask them. So what stain, do you remember what stain we should do? Negative, negativo. This is negativo, we say? Okay. What else? Negativo. TTF1, negativo. What? Sorry, I didn't hear. Huh? Negativo. So here you have a problem because this is from 2005. I'm sorry to disappoint you. At that time, there was no BRAF. Think about the older people. Sorry, don't take it personally. Why? They had a rough life. You know, these people are so spoiled. Okay, BRAF, I have no idea. So let's say you are Dr. Mattia in 2005. He was young, full of life, and what you gonna tell them? Of course, there are very good surgeon oncologists tell you, is it anaplastic? Please, let me know. Please, is it anaplastic? I'm waiting for you. I don't know, there were cell phones into that, so call me on my cell phone. No, send me an email. So, okay, how are we gonna word it? Who wants to give me like wording? I mean, between you and me, we know this is anaplastic, but how would you, yeah. Well, like, yeah, how would you word it? Nobody wants to tell me? Okay. What? Okay, then, but is it anaplastic or sarcoma or melanoma? He asks you, please. Huh? I don't know if I did it at that time. I don't remember. Negativo. Let's say negative. Well, I'm speaking Italian. Huh? Negative. But you know, the patient is, and the wife is saying, I love my husband. He was a great guy. He was a surgeon, for example. I don't know. I want to know, please. Everybody waiting for you. Should I do a tracheostomy or not? Should I tell this wife and him that they have to do life planning? They're not gonna live. There was no targeted therapy at that time. They have to he has to put his things in order, like he has to. If he didn't write a will, you'll be surprised how many people don't have a will, even our age. Yeah, we know where the beautiful farm in Trento will go to, which son, the favorite son. So what should we do? Huh? ALK1, I don't know if ALK was... lymphoma markers negative. Well, it's not my fault. This is the nature. Believe me, we should never underestimate cancer. So how do you word it? I mean, how do you word it? Well, let's ask Professor Italini. How would you... Okay, I'm the surgeon. I gave you a wonderful biopsy. You such a, come on, Giovanni.
It's
Yeah.
an incisional biopsy. So
What do you want more? I mean, I gave you a biopsy, and tell me,
So
how would you word it? That's the question.
I would go back to what you said at the beginning of your lecture, never to make or not make a diagnosis of an anaplastic cancer without talking to the clinician.
Okay.
So what really counts is the context. If you have an undifferentiated, anaplastic means undifferentiated. Anaplastic is Greek, undifferentiated is Latin, but they mean the same thing. An undifferentiated tumor that, like you showed very nicely, can be either epithelial or squamoid or sarcomatoid, right? Centered in the thyroid, negative for everything. You know, patient has been staged.
Yeah, by the way, the patient has been staged, and there's nothing in the lung, there's nothing in the kidney.
That is anaplastic thyroid cancer.
Okay, but okay, now I agree with you.
Consistent with, I mean, obviously.
Ah, voilà. So the way I would word it, now tell me if it's wrong, I would say the following. Anaplastic malignant tumor, consistent or most consistent with anaplastic thyroid cancer. By the way, this business of consistent with, I don't know how you say in Italian. How do you say?
Compatibile con.
Yeah, it depends what hospital you are in. You have to be very careful. I don't know here, you can tell me, but at Memorial, this means it is. I mean, if you say favor, because you have to understand the oncologist, the worst thing you can tell them, I don't know what it is, because they have to put the patient in the box and give treatment. Because, you know, the worst thing for an oncologist is not to treat. Although sometimes they should be honest and say there's nothing can work for you, Mr. Smith, and we're going to let you die. But hospice care. But the worst thing you tell them, so they will beg, if we forget of thyroid, for example, in the neonatal, they beg for no endocrine positivity because they can give platinum-based therapy. So they beg for it. So we say anaplastic malignant tumor consistent with anaplastic thyroid carcinoma, C note, in the note to say the immunostains are negative for blah, 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 blah. Now, according to Dr. Smith, this is a rapidly growing tumor that is thyroid-based as per CT scan. Based on all the above feature, this is most consistent with anaplastic thyroid cancer. That's how it should be done. And I put, of course, case discussed with the, yeah. And I can tell you, once you put that compatibile or consistent with, the good news is that can put the patient in any clinical trial. Because the clinical trial, the worst thing they want is to give them a poorly differentiated, and then they found out the tumor does well, but the drug did not cure the tumor. Yeah. So basically this is, I put this case just to talk about the wording of this. So actually, yeah, it could be completely negative. Now, you have to understand that we call this carcinoma, but probably, at least biologically, it's not a carcinoma because we have shown epithelial mesenchymal transition at many levels in this tumor. But Dr. Ghossein used to, and still now, we think we call them anaplastic carcinoma, but this is more like a sarcoma, don't you think so?
Absolutely. I mean, there are sarcomadoid carcinomas or sarcomas, but you know.
But BRAFs change everything, because now if you tell them BRAF positive, they will be like dancing in the street. They'll be so happy for this patient. They will call them and tell them, look, you're extremely unlucky, but you're very lucky in your bad luck and stuff like that.
I think we should be grateful because this case really illustrates the practicality of you know, making diagnosis of anaplastic carcinoma with dreadful implications for the patient. And essentially, you know, you do have some of these tumors that are totally negative, but if they are centered in the thyroid, they are anaplastic carcinoma by default, essentially, and that's what is to.
Okay, now let's jump to another case. This is, remember, everybody is quite old here, I don't know, 84-year-old lady with a tracheal mass. So let me tell you the story of what happened here. So they took this lady to surgery, and they wanted to do, I think, a thyroidectomy, if I remember. It's such a long time ago. But what happens that, like always, before, you know, intubating the patient, the head and neck surgeon will look into the trachea. They saw a little pimple thing, submucosal, going in the trachea. So I think I'm wrong here. I don't know if they did a core biopsy. I don't know. But maybe they just biopsied from inside the trachea. And I have to tell you, they sent it for frozen section. I don't have the frozen section. I like Giovanni to show off this case, although, you know, I don't know if I deserve to show off this case because, all right. So here they tell me, they call me, and they tell me, Okay, Ronnie, please, please. This is an old lady, and please, I don't want to do. If you tell me papillary carcinoma, I'll do commando surgery. I mean, I'm not even sure I should do it. But if you tell me it's anaplastic, I stop everything. And this was, tell you when, this was in 2003. Oh my God, all these cases that Mattia has to deal with. Okay. Sorry, let me be sure it's the case. Just 1 second. Saying something. Yeah, this was also in 2003. Sorry. So yeah, so frozen section, and I mean talking about being lucky. It's better in life to be lucky than good, of course. Okay. Okay. So here you see that there is definitely a nasty component here, nuclear pleomorphism, even neutrophils, I think. And what is that? Is this anaplastic? Who think this is anaplastic? So here you have a component that makes papillae. So, all right, so how would you report the frozen section? Papillary carcinoma, do commando surgery? Or anaplastic, back off? Now, of course, the patient could have another undifferentiated tumor. She's an old lady, it could be a melanoma, it could be anything. Huh? It could be lung. But but here actually it is an easy diagnosis of anaplastic because you have a better differentiated component with it. So actually I told them I think it's anaplastic with a better differentiated. Well, I was like a hero. And they of course aborted the surgery. Unfortunately there was no treatment at that time. So Giovanni, at that time, if you have invasion of the viscera of the neck, basically they leave you, they tell you, okay, we're gonna do chemoradiation, and the patient basically after that will go to hospice. I mean, after, sometimes the chemoradiation, because this is a rapidly growing tumor, sometimes they used to respond a little bit, but now we have BRAF. So let's look at here at the immunostain of this case. TTF1 positive. TTF1 negative in the anaplastic component. Here you see thyroglobulin. So there is positivity, not a lot, but it's not that surprising. You see, don't think that in papillary carcinoma every cell should be positive for thyroglobulin. Actually, in the 60s, before immunostains, I think they used to do, I don't know if you read this paper, Giovanni, where they did liquid assay and they found less thyroglobulin in papillary carcinoma than in, of course, follicular carcinoma and normal thyroid. So it is, no, papillary carcinoma is not, you know, not every cell should be positive for thyroglobulin.
The degree of expression, I think all of you should know this, right? Is normal tissue, follicular adenoma, follicular carcinoma, well differentiated. They express a lot of thyroglobulin. Then papillary carcinoma, the expression is decreased, and then fully differentiated is not like.
Yeah. So thyroglobulin is negative in anaplastic carcinoma, but sometimes it can be positive. Why? Because of passive diffusion. I'll show you a case. Not of anaplastic, something different. Because thyroglobulin is a good marker. It can be sometimes positive in lung, but unfortunately in the thyroid, there's thyroglobulin everywhere. So you may have sometimes passive diffusion, and the people, as doctors like to say, you make the right diagnosis for the wrong reason. Okay, one more immunostain here, so people can see really how these look like. This is P53, and there's no nuclear stain, or not much at least. Yeah, so this was a good amount of P53 immunostaining. Unfortunately, it's not, I have no idea what this is. Unfortunately, it's not always that easy, the diagnosis of anaplastic carcinoma. Here, basically, it's like winning the lottery, because what is the chance that he got, it was Shaha, by the way, Jovan, that he was papillary and anaplastic on frozen section.
That's
also.
Very lucky.
On frozen section, I mean, like, everything, yeah, is very, very lucky. All right, now we're gonna get into more difficult stuff. So, Stick's life is not that easy. 63-year-old lady with a history of goiter and Hashimoto for 40 years, fine. Now she presents with enlargement of some of her thyroid nodules, and one of the nodule grew in 1 week. Ooh, not good. Sorry, this thing is a little bit difficult for me. This is really an unusual case. So here, let me tell you how I lived this case. So this was, this was, anyway, it was in 2003. Okay. So here the situation that we're facing. So we have an undifferentiated tumor, but really there's not much nuclear pleomorphism. And you have this multinucleated giant cell. And let's see, it looks invasive here. Oh, look, I found vascular invasion. Like the one you find in the oncocytic carcinoma or follicular carcinoma or follicular variant, hanging in the lumen, covered by endothelial cells. Maybe here there is something else. Okay. So, I'm not sure this is invasion of the vessel from outside. Anyway, the question here, so what I did, because there were not much nuclear pleomorphism, I told myself, let me do a Ki-67. And it was low. I mean, it was like maybe 10%, 6%, 7%. I said, oh my God, what is this? And they told me, look, you know, if it is anaplastic, you're going to leave her alone. So you have to tell me whether it is anaplastic or not. So I looked for mitosis, found very little. I looked for tumor necrosis. I don't think I found. But, I mean, it was clearly carcinoma, clearly invasive, and it didn't, I'm sure I had done TTF1 thyroglobulin PAX8 that were negative. So there was, I mean, I was relatively young, and they keep telling me, look, you have to decide, no. So luckily, the worst thing that happened to a pathologist is to be alone. Luckily, there was an older somebody who was more experienced than me, David Klimster actually, who trained with Dr. Ozai, and he saw a lot of his tumor. He told me, oh, this is probably a giant oxaloclast giant cell rich anaplastic carcinoma. I said, you know, David, if you agree with me, we're going to make this diagnosis. And actually, there was an area where it invaded the vessel from outside. Sorry, I can't find it. But that also reassured me a little bit. And you know, I was feeling very afraid. And then, luckily for me, not for the patient did very poorly and died 1 year after diagnosis. She had actually compression symptoms very rapidly progressing. So we were lucky here. So this is just I put that case just after the other one, which is an easy case, show you how difficult sometimes it can be for anaplastic, to diagnose anaplastic thyroid carcinoma. And, but in a sense, it was here a question of exclusion. I mean, There was no other thing, no other way to, no other tumor that really filled the criteria here.
Ronnie, may I ask, what was the clinical context? I mean, the patient, because when these things happen, it is essential that the patient gets accurately staged.
Yeah, so
Because
basically,
that helps.
yeah. So basically, she had goiter for many years. Then, as I said, within 1 week, one nodule appeared. So that's bad, yeah. And actually, the follow-up was catastrophic. You know, it was rapidly progressive. Yeah.
Did she have, you know, like other main tumor masses?
Yeah, there
around?
were metastases in the lung. It's funny that I remember after 20 years.
But multiple.
Multiple, yeah.
So it was not compatible
No,
with, the
no,
lung,
no, no.
with any other.
No. It was
But
not.
It doesn't look like a carcinoma anyway, but
Yeah.
it is important to have this clinical
Yeah.
pathologic correlation. Like you
Yeah,
said.
actually, it makes me think. I hope I should get the block and stain this, genotype this to see if something can help us if there are BRAF V600 positive. Forgot what we found in the paper. But anyway, I wanted to show how it can be very easy or very difficult. All right, now we're gonna ask the audience. All right, 79-year-old female with enlarged thyroid isthmus and lymphadenopathy. Okay. Sheets of cells. All right. Everything looks like this. So there are mitoses. There are these cells with big nuclei, big nucleoli. So the audience, somebody want to volunteer a diagnosis? Okay, and let me give you 4 multiple choice, young people like that. Melanoma, anaplastic carcinoma, lymphoma, sarcoma. Always put an easy one in the. What? Sorry, lymphoma? Lymphoma? Angiosarcoma. Okay. Well, when I look at the H&E, I picked up the phone and I told the oncologist, look, really, this is the outside case, but I think it could be a lymphoma. He told me how long it will take you to get the slides. So this is, again, was in 2000, what happened in 2003? My God, everybody had anaplastic carcinoma. Okay, so it was 2003. I told him, look, you know, it's gonna take 1 week, even if it is in New York, you know, they have to send it, we have to give an accession number. He said, give me a break, what's your differential? I said, lymphoma versus anaplastic. Told me, don't worry, I give radiation therapy. If it melts down, it's lymphoma. I said, no, you have to wait. So we waited, and it was negative for all lymphoid markers. So my impression was wrong. It was focally positive for AE1, AE3. So I don't know why they thought they can take him to surgery. So they took him to surgery, and kid you not, it's a real story. He recurred, now listen, Mattia, wake up. 2 days after surgery, 2 days, with a mass larger than the previous one. This is very humbling, you know. First, I thought it was an lymphoma. Then it's a horrible anaplastic carcinoma. Now, I'm sure the patient died. Again, it will be very interesting to genotype these cases. I have to go, maybe we genotype them in our study. So, all right. But, you know, I was not wrong all the time. There's one case where, okay. So now, the good news now, my friends, that now we're not in, yeah, actually now we're still in, we're still in 2002, bummer. Okay, but something happened in between. Yeah, okay, so 57-year-old female with a lung nodule and history of thyroid carcinoma. I forgot what it was. They even didn't submit the slides. So there was one nodule, so they panicked. They said, my God, I'm not sure it's metastatic PTC. Maybe we should go and do a wedge biopsy. And then we ask the pathologist, and he will solve everything. What I love about my hospital, then in tumor board, everybody says, not the clinician, but the radiologist especially said, okay, now I let it to Ronnie and Nora because pathology is king. Or queen. So they admit that. Then we tell them we don't know. So this is the lesion in the lung. Okay, all right. It looks like a carcinoma. Oh, there is fibrosis and anthracotic pigment. Yay, okay. The whole is because we use this for tissue microarray. And here, it's squamoid, okay? You have to believe me. I mean, it's an old slide, but it's squamous cells. All right. So I don't know if she was a smoker. So squamous cell of the lung, finito la musica, leave her alone. Or what should I do? Is it possible to be, so when I said it looks like squamoid, so one of the surgeons said, okay, so it's not thyroid. You know, because a lot of people do not know that thyroid can have squamous cells. You know, a lot of clinicians do not know that. So, is this cancer? So here we are in two choices. Okay, I give you two choices, guys. Okay, metastatic anaplastic squamous cell carcinoma transformed in the distant side versus squamous cell carcinoma of the lung, and how to get me out of this dilemma. What? That's the good answer. But on morphology, what do you think? Impossible to tell, right? Okay, so yeah, we at that time PAX8 was available. Okay. Molto bello. Okay. So that was PAX8 positive. So it was metastatic anaplastic thyroid carcinoma transformed from a tall cell variant. She was 57-year-old, so it's okay, the age. And yeah, that was the end of the story, the power of PAX8. But this was at that time polyclonal PAX8, but there is something much better now that is monoclonal PAX8, and I will show you a case in the last lecture. Okay, let's jump. Go. Okay, that's a very good question. I was going to say it in the talk after, but I'll repeat it. So actually, you're right if you're relying on monoclonal PAX8, but we found out that polyclonal PAX8 actually, in the beginning, actually we did one of the first paper on PAX8 with Daisuke Nonaka, who trained here. He used to say sono Japanese, who came to work with Dr. Ozai, fantastic pathologist. He's now in England. So so Daisuke and I did one of the first papers. So polyclonal PAX8 unfortunately can stain some lung cancer, but we found this after 10 years, you know, and now we use monoclonal PAX8.
It also cross-reacts with PAX5, so it can also stain with a blush large cell lymphoma. So it's a little. Plus, you know, there is always, with all these markers, like Ronnie said, you know, they are very helpful if they are positive. But if they are negative, you know, like the first case he presented, they do not still rule out anaplastic cancer. So.
Yeah. Okay. So, all right, let's look at this case. So this is a patient who had a thyroidectomy. And okay, we're not gonna lose time here because we are a little bit short of time, so I want also Giovanni choice cases. Basically, to make a long story short, this was diagnosed as anaplastic carcinoma, and there were other reasons for it. At that time, there was no PAX8, but it was everywhere. It was in the jugular vein. I think this is one of the veins here. And what is incredible about this case, that this lady, she was 52-year-old, she kept recurring, and every time she recurred, see, I showed you just before a case where it transformed anaplastic distant side. Look how tumors are humbling. It recurred, Giovanni, look at this, really you'll like it. It recurred as non-anaplastic, as even poorly differentiated thyroid carcinoma. There was necrosis, maybe not the best on this slide, but please believe me. And if you don't believe me, I can show you my, I think this was the thyroglobulin. So this is a lady that kept recurring as poorly differentiated, and last time I checked, we had 14 years follow-up, she was alive. Unbelievable, unbelievable. That is fascinating. A very odd case, unfortunately, but that's to show you that we were saying nearly always fatal, but of course, you know, medicine, we know that biology is not perfect. It doesn't read the textbook. Okay, maybe I can go now quickly. Giovanni, tell me if you want me to stop. But here I want to quiz them with one case, okay? 46-year-old female with multiple nodules in right thyroid lobe at age 12, left thyroid lobe was resected for goiter or whatever. Okay, oh, sorry. All right, so there is fibrosis. Yay, look, there's squamous. Differentiation, so maybe it's squamous anaplastic. There is mucus. Okay, okay. I'll show you more. I'm not a jerk. I'll show you everything. The slides was old. So this is the squamoid area. If you don't believe me again, this is a mucin intermingled with the squamoid areas. Okay. Yeah, and there's something here that I don't know if it shows up well. Huh? Who said what? What did you see, Mattia? Yeah, mucin production. And here there is, first time I do this. Well, I'm not going to say it. What is the differential diagnosis? Yeah. So what's the diagnosis? Anaplastic carcinoma? What? Yeah, because you told them. Okay, it's not fair. So it was sclerosing mucoepidermal carcinoma with eosinophilia. I don't know if you see them well. Sorry, I had another, I mean, every 10 years I have one case. So recently we had a much better case. I scanned it, but I didn't think the eosinophils. You saw them, right?
There are some people that say that eosinophils are not really a requisite, that can be very sparse in this type of very rare tumor.
Yeah. Or the one I had recently, it was like there were abscesses of eosinophils.
So it is not true that, you know, they are still part of.
I mean, I don't know how many cases did you see? How many cases?
I never diagnosed one. I've seen them.
What? You're not that young. Okay, no, I have seen three cases. They all had eosinophils. But, you know, the really important here is not to confuse it with anaplastic thyroid carcinoma. And here, this is really important to look for nuclear pleomorphism and so forth. Now, some people die of this disease, sclerosing mucoepidermal carcinoma with eosinophilia, but they usually develop anaplastic carcinoma, but much more obvious. And in the new WHO, I don't know, for those of you who adore thyroid, maybe like Chiara, the origin, what did we decide? That it is unknown cell of origin. Some people think it comes from the solid cell nest. I really do not care, to be honest with you. I don't care where the cell is coming. I'm just where it's going. Yeah. It's like in America. We don't care where you come from. We want to know where you're going. All right. One more really unusual case.
Can I go with my things?
Okay. Yeah. Okay. You can go. But I just want to show them one case. 2 minutes. Yeah. And then we solve it. Maybe yeah. So this is 40-year-old female with a cold nodule in the left lobe. Anaplastic or no? Huh? Remember, she's 40 years old. Huh? Yeah. Yeah. So lymphoepithelial-like anaplastic, it exists, yeah. Although, to be honest with you, I don't remember seeing one case. But there is something unusual for anaplastic. It's like well-defined, and it's look like it has septae, you know, it's like, huh? Bravissimo. You always need an old man. Sorry. Yeah, so this is, thymic carcinoma, interthyroid thymic carcinoma. Actually, the CD5 is positive. This is, Dr. Oza used to call them Castle, now that we changed the name. And you have this one, I see one every 20 years maybe. CD5. Okay, Giovanni, the floor is yours.
Well,
And,
the microscope.
Well, the microscope yours. But I have other interesting cases, but tomorrow in the medullary session, we can squeeze them in.
I'm learning. Sì. Questo non gira. Okay. So this is a 62-year-old woman who is presenting, still in the theme of aggressive thyroid cancers. Presenting with a 10 centimeter thyroid tumor, which is replacing the left lobe and extending to the anterior neck and the lateral neck. So, and this is what we got. What would, your differential be in general? And what would you, do from the practical point of view? So 62-year-old woman with 10 centimeter neck. That's a very good thought. The other thought would be malignant lymphoma, right? So that is more or less what I wrote in the report. He either, and I said, we tried to do immunocytochemistry on sections. He used to work at Memorial, but now we have lost competence. So essentially, I asked for an incisional biopsy, as per previous comment. And this is what I got. Right, first I have to, okay. Right. So there were bits and pieces of tumor, ash artifacts. Portion of it was here. By the way, meanwhile, the patient had been staged, and he had little nodules in the lung, but no major, pathology. Oops. So Well, we did, as you can imagine, all sorts of markers that were either, uninformative or negative altogether, basically. And personally, I thought that this was going to be some type of lymphoma, also giving the clinical picture. We did immunohistochemistry that showed this. This is PAX8, the famous PAX8. Flash of positivity, some more positive cells. This is monoclonal. I mean, the case was from, I still didn't know much, so I asked for a real incisional biopsy, and that's what I got. This doesn't make our life easier, actually. But at least there is diagnostic material that you can do reliable immunohistochemistry on. So basically, there is a small two-cell tumor component. Then there is a sort of looking cell component. So, you know the diagnosis. So what do? Well, we repeat all the immunos that were done before. And, well, just to give you an idea, this is the Ki-67. 62. He's actually my age. Very young, yes. So this is a pediatric tumor, right? Okay, I mean, this is Ki-67. Basically, every single cell is proliferating, both in the small cell component and in the sarcoma as well. Okay, so then we again repeated all sorts of things, and let's see. Keratin was done, was basically positive, only very focal. This is INSM1, which is, like the fancier and newer version of chromogranin to call something neuroendocrine. Strong positivity in the small tumor component, which was also confirmed by chromogranin and synaptophysin, but that's all right. We did PAX8. Showed some serial nests that were positive, sort of irregular fashion. We did CD99 that was negative. Keratin was very focally positive in some of these nests. So what to do? Well, we thought hard, and actually, at at that point, since this was felt to be, at least behaving like an anaplastic thyroid carcinoma, we did genotyping of the tumor, and we got a completely flat NGS profile with DICER1 mutation, which, putting everything together, particularly with the histology, which is also quite typical, brought us to do additional markers. And this is SAL4, which is a stem cell marker used to diagnose non-teratomatous germ cell tumors, and you can tell that in the small cell component well, sarcomadoid one. Although actually, interestingly enough, these are these epithelial nests that were positive for axates, and since they're better differentiated, not express the
that's SAL4.
yes.
Then SMARC B1?
Sorry?
SMARC B1?
That was negative.
You mean it was not lost?
Meaning it was negative for loss. I mean,
it
was not lost.
I mean, okay.
Yeah.
Because sometimes
And
SAL4 are...
That was negative. I mean, and then we also did the SOX1. Which was negative in the
Sorry, Giovanni. SOX1 for me is unknown.
sorry?
SOX1 is unknown for me. What is it?
SOX4.
Sorry.
SOX2, sorry.
SOX2, okay.
SOX2. It is another stem cell marker which marks neuroepithelium. And so basically, by putting everything together, this is essentially a malignant teratoma, and which is now called thyroblastoma. And it is a very rare tumor, exceedingly rare, characterized. I actually had prepared some PowerPoints, but probably there is no time to show them. It is diagnosed based on the presence of small round cell tumor component, which it's immature because often it is of neuroepithelium type differentiation. Then there is a sarcomatoid component, mesenchymal sarcomatoid component. And then there are little nests of epithelium that are reminiscent of primordial thyroid follicles. And there are 8 cases reported so far in the literature. All of them have got DICER1 mutation, and this, I think, would be the 9th. Now the patient, after the right diagnosis, has been treated with chemotherapy. She's now in remission, and we're going to look whether she has got germline DICER1 mutation. Keep in mind that, I mentioned in my talk DICER1 syndrome, and in children, the syndrome was discovered because they did whole exome sequencing on a child who had pleuropulmonary blastoma. And then they found the DICER1 mutation, and then they kept on, expanding the phenotype. And soon enough, they found out that some of these patients had, either differentiated thyroid cancers if the patients were young, or multilocular goiter if the patients were older. And then other tumor types, certainly like tumors, embryonal rhabdomyosarcoma, etc. But in all this spectrum, very diverse spectrum of tumors, thyroblastoma has never been included. So to date, thyroblastoma, although it is characterized by somatic or at least tumor-linked DICER1 mutation, is not clear whether this is part of the DICER1 syndrome. From the available data, that does not seem to be the case. And of all these 8 cases, none apparently has been tested germline or could be tested, because many of these patients died. They've often been misdiagnosed initially. They were retrieved only afterwards, and I think that is the case of my life, because I've never diagnosed one, and I've seen only 2 cases with Catarina Eloy from Porto that she has been collecting these cases. And the take home, what I've learned from these cases is that if you think about the cytology, where the differential diagnosis was, it had the clinical presentation of an anaplastic cancer, basically. And I was, like Ronnie said, under pressure. The patient is dying, she's dying suffocated, etc. So I took my time, and they said, well, give me an incisional biopsy. I got the first one that was unreadable, basically. And then finally, I got, all these took 3 weeks, more or less. But then the patient got the right diagnosis, the right treatment, etc. And the push from the clinicians to call this anaplastic thyroid cancer, was great, but I resisted it because it didn't look like one, simply. So what I've learned personally is, first of all, you have to do clinical pathology correlation, have the patient stage, and she had little, foci of metastatic disease to the lungs, but no major lung mass, no major mass anywhere else. So it was really a thyroid problem, not only histological, but also from a clinical point of view. And so it didn't look like anything. It could have been a metastatic neuroendocrine carcinoma, which is what Mattia thought correctly. In fact, there was, I didn't show it, but there was a little bit of synaptophysin in the first, in quotes, needle biopsy. That was inadequate. But there was no lung mass. And there was no clear-cut expression of lymphoid markers. And the other thing that I've learned is that, molecular is actually useful, and we're lucky to be able to do it, because, the finding of DICE1 essentially solved the problem, because it was completely flat. I mean, the NGS profile was, there was nothing else but a pathogenic exon 25 DICE1 mutation. So that's one case. I don't know, I probably don't have much time, but so this is a 64-year-old woman with a widely invasive carcinoma of the thyroid gland. Sorry, let me. Sorry, first look at the. Let me screen the slide. So just scanning at low magnification, shows these multiple nodules that clearly define the tumor as widely invasive. And we know, this is cancer. Period. There is no indication. And there are these areas. Which type of growth pattern is this? Yeah, exactly. I mean, this is a poorly differentiated carcinoma component. It's the mouse. There is no. Maybe I can. It's the mouse, right? There is, not going to count mitosis, but there are So this is a fully differentiated carcinoma tumor, and so this area here illustrates, you see that, illustrates this peculiar finding that Ronnie is already laughing, but of poorly differentiated thyroid carcinoma in the twin consensus, is, you have invasive carcinoma, thyroid insert, no well-defined features of papillary carcinoma, and then either one of three items: mitotic activity greater than 3, tumor necrosis, or these raisin-like nuclei, right? And this is, one of the criteria. So theoretically, you could even have a poorly differentiated carcinoma without mitosis and without necrosis if you find this. These are raisin-like nuclei. Raisin sarebbe uvetta in italiano. And, convoluted contours, they're hyperchromic or hyperchromatic. And, they are felt, Dr. Ghossein felt that these represented, and it is true, a poorly differentiated version of the nuclear alterations you find in papillary carcinoma.
But what about, you see this? It's like this without necrosis.
No, in fact, they all travel together, but,
So then, why not dropping that thing?
Well, it was
I'm afraid that somebody will see with not my foot necrosis and late validation. But I'm happy that finally I understood what it is.
Okay. Well, they are wrinkled nuclei, which are expression of a poorly differentiated.
No, I understand. I think it should be a flag that you may be doing good. But I don't know, if you prove that cases by themselves, this is by itself, an indicator of poor outcome, I think
I mean,
we never had a case without, so we can.
in any case, whatever I'm sure you're right, but I mean, no matter what, these are a feature of one of the features that you find in poorly differentiated carcinoma. So it is worth, I'm sure you are correct that they have no prognostic. I think it has also been shown that they have no prognostic value. But it is a traditional, well, whatever. They exist. But the reason why I'm showing these cases is not because this is a poorly differentiated carcinoma, which clearly is. It is widely invasive with a poorly differentiated. And then, this time I got organized better than the first session, and I put dots. And get these.
Very nice.
Actually, so this is incipient tumor necrosis.
I don't know.
No, you don't know here. He doesn't know.
Fully differentiated in the other
Right. In any case, we are already in the poorly differentiated arena. So we may discuss forever whether, but whatever. It's cellular debris. There are no apoptotic bodies. But the reason I'm showing these cases is because of the nuclear feature. These are follicles, okay? But they're lined by cells that clearly have hobnail features, right? And they slough off into the lumen. So this is a true hobnail component in a tumor which is high grade. It has a poorly differentiated carcinoma component, and these sort of follicular variant papillary component with hobnailing. There is more of that. Sorry. Again, the cells really slough off into they're associated with this. What counts is that these cells are really atypical. And so, in my talk, I briefly mentioned that, you should be careful not to overcall hobnail. You can find hobnailing, particularly in cystic papillary carcinomas or in papillary carcinomas that have a cystic component. But in addition to that, you need to have significant nuclear atypia, and Ki67 should be high, and sometimes you can even find p53 overexpressed. So, and actually, there's another thing to point out. That for some reason, since these cells slough off into the lumen, when you stick a needle into them, they're, you find them on more easily on cytology specimens than on histology. This is rare, but I mean, this is one case that had a very minor hobnail component, and actually, when I first looked at this, I called it positive for malignant cells, but the cells here, they look even more malignant than your normal range for papillary carcinoma. So I thought, well, this, maybe it is a metastasis to the thyroid gland, looks like another carcinoma. Maybe it is, an anaplastic thyroid carcinoma, oops, excuse me. But, this is the equivalent of the hobnail pictures on cytology. You see them, and actually, they are, these are rare tumors, but cytology is more telling than histology sometimes, because I showed you like these cells sort of, since they're poorly differentiated, they slough off, they fall into the lumen, and then when you aspirate them, they're easier to find on cytology specimens. And these are the ones, and these are more, less unusual papillary carcinoma cells. But the atypia here is beyond what you normally find in coffee break? Okay, then I can finish here.
Let's have 10 minutes break. 10.
I would the talk on anaplastic cancer.
Do you like it? You know who did?
Your best.